Good afternoon and welcome to the Texas Primary Care Consortium's webinar on advancing firearm safety and injury prevention in Texas. We are really thrilled to see so many friends and to welcome those new friends for whom this may be your first webinar with us. We could not be more pleased to have two outstanding speakers for our discussion today, Drs. Emmy Betts and Dan Guzman. You will learn more about them during the discussion phase of the webinar. You can also find their speaker bios on this page. Next. Me? Yeah. Okay, well, let's get into it. So what are we going to do today? What do we hope to accomplish? Well, our learning objectives are to understand the factors that contribute to firearm injuries in Texas. We really have to, if we're going to approach this problem and try to improve this problem, we need to understand the contributing factors. We're going to learn more about real-world examples that demonstrate successful integration of firearm safety into clinical practice. And finally, we're going to discuss prevention and community-level strategies in firearm injury prevention. Next slide. Well, who are we? So we are the Texas Primary Care Consortium. We are the only statewide collaborative initiative with a mission to advance equitable, comprehensive, and sustainable primary care for all Texans. We are co-led by the Texas Medical Home Initiative and the Texas Health Institute. Next slide, please. Well, how do we do our work? We do our work through a combination of collective action and a network-based approach. We called it the EAT, the Educate, Activate, Transform framework. So we expand our knowledge base by sharing best practices, lessons learned, and replicable tools, and that's some of what we're going to do. We activate, we facilitate opportunities to build and strengthen lasting partnerships for shared and sustainable impact. And finally, we transform, we create spaces for dialogue and action to generate a shift in the healthcare system through policy and system change initiatives. Next, please. Thank you. We really could not do this work if it were not for the support of our very generous partners that you see featured on this screen. So thank you to our partners. Next. Also, thank you to the amazing Texas Primary Care Consortium team. You see our team members listed, and I can honestly say I love coming to work with these people every day. It is a tremendously supportive, tremendously smart, thoughtful group of people, and it is just really an honor and a pleasure to work with them. So thanks, everybody. Next, please. Well, I think to set the stage for our discussion today, we really do need to look at some of the data. Now, I think there's a tendency with data presentations really to share too much data, and we don't want to do that. But what we do want to do is really to frame the fact that we do have an increasing problem in Texas with firearm deaths. You can see they've increased significantly, almost by half. From 2012 to 2021, and that is significantly higher than the national average. Next, please. So as I think many of you know, more than half, very close to 60% of firearm deaths in Texas are due to suicide. This has also increased over time. And a great concern is the fact that the age group that experienced the largest increase in firearm suicide was the age group 20 to 24. At the same time, firearm homicide rates are increasing in Texas, and by significant margin. And also of very great concern is the fact that between 2011 and 2020, and that's really even the early days of the pandemic, so we can assume that has increased since then. In the United States, there was judged to be about a 15% increase in firearm perpetrated intimate partner homicides. In Texas has increased to close to 82%. So this is just really very concerning and something that we have spent a lot of time looking at and will continue to do so. Next, please. And sadly, I don't think that we ever thought that this day would come, but firearms are a leading cause of death among children and teens in Texas, as well as nationally. And I think if there's one statistic that can galvanize people from all different walks of life, all different professions, and all different philosophies, I would hope that this would be it and really could be a call to action. Next, please. So let's look at this, because this is a complex set of circumstances. So we used what we call the Swiss cheese model here. And this was adapted from a model for COVID, but I think it lends itself really very nicely to our way of looking at reducing firearm injuries. So there's a whole lot of, and the reference to Swiss cheese is that there are many, many holes in Swiss cheese, but if you line a bunch of pieces up together, you're gonna close some of the holes. So we look at things like safe storage. How do we mentor our children? And we're gonna hear more about that later. If we hear something, we say something. Media consumption. So we vote, we advocate. And again, when a big part of our talk today is going to be about clinicians. How can clinicians talk to their patients and their communities? I think it's absolutely critical to engage gun owners in this discussion. I'm a gun owner, and I think that engaging gun owners is essential in really moving forward with this. If we have anonymous reporting systems, trauma-informed healthcare, we have to build teams and care teams in schools, places of worship, workplaces, to build a stronger social safety net. We know that a lot of this really is an erosion of social cohesion. We need bipartisan policy. Again, this is a nonpartisan, bipartisan, should be keeping our people safe. And also community level change. Another thing that is critical is to support research. You probably know that for close to 30 years, there really was no officially funded research on the federal level into firearm injury. Fortunately, that has changed and we're starting to catch up, but we have a lot of ground to make up. So that is one of the ways that we look at how we reduce this. Again, there are many, many different layers to this, but ideally they can all overlay and we can work together. Next, please. So what did we do? Well, we as a group, as a team, decided last year that it was time for us to really embark on this topic. And so we engaged a group of community members and leaders to understand firearm injuries and death as a public health issue, and also the factors that contribute to firearm injuries and death. This group discussed strategies for firearm injury prevention, and this is the framework that we adopted for the solution. So we do 3 levels. So we build on the individual clinician's role, so at the individual level with the patient. We build on existing interventions and evidence. What is that evidence at the individual and community levels? And finally, we do what we like to call, we normalize the conversation. So, and this is at a system level. We're able to have this conversation like we talk about a lot of different things in terms of protecting people's health. And so our goal as a group was really to take a comprehensive look at the growing rate of firearm injuries and deaths and respond with this framework that would act in the following ways. And we also want to acknowledge that there has been some good work that has been done in our state. The Texas Department of Public Safety has a program called Keep Them Safe Texas. It's our legislature funded that the last biennium. It's a website on safe storage, and also the passage of a requirement that schools distribute safe storage to parents. So there are some signals that there is some movement here in Texas. Next, please. So, drum roll, we are very excited to share today that we are publishing today is the debut of our firearm injury brief. And this goes into the framework that I just presented. It also summarizes the group's insights and ideas for next steps. And the brief will be on our website. And we really want to hope that you look at it and that you share it widely. And our primary care consortium team will continue to work with our stakeholder group to promote firearm safety and injury prevention. So we're very excited about this, and we're glad that you're here with us today to experience the debut. Next, please. And those are the references that are in our brief. Next, please. All right, now it is really a pleasure to introduce our two panelists and to really to learn from them. These individuals are both leaders, thought leaders, action leaders in their respective communities. Dr. Betts in Colorado and Dr. Guzman here in Fort Worth. They're both emergency medicine physicians. And we're just really excited to learn from them. So I'm going to ask Emmy, Dr. Betts, and I will refer to them by their first names because that's what we like to do. So I'm going to ask Emmy. Emmy, tell us about your work and how and why you got into working on firearm injury prevention, please.
Yeah. Thank you, Sue. Thank you so much for inviting me to be part of this conversation, and congratulations on the great work that you're doing. So I'm an ER doctor in Denver. I work in a large a trauma center that mostly cares for adults. So I'm a little scared by the kids, I will say. So most of my clinical work is in the adult space. And the firearm injury for me has been important in really two clinical settings, I would say. So the first is we do see a lot of young adults and late teenagers who have been injured in community violence. And I'm very grateful that our hospital now has a wraparound violence intervention program that we can refer youth to try to break those cycles. But I think an even bigger role for me, I've really felt has been in the space of suicide prevention. I think Colorado, like Texas, the majority of our gun deaths are by suicide. We actually don't see those individuals in the ER. I think in my career, I've seen only one person who came in after a suicide attempt with a firearm and then died in the ER. And we don't see them because they usually die at home, but we see very large volumes of people who are struggling with suicide risk for various reasons, whether it's mental illness, social crises, just life piling on at the same time. And I think one of the most impactful things we can do for them is educate them and their families around how they can make their homes a little bit safer while they're getting better. Because we know that access to a gun in the context of suicide risk increases the risk of death significantly, not because the gun makes someone want to kill themselves or even think about it, but it's because in that moment, if someone reaches for a gun, there's no second chance. 90% of the time they die. So I talk about it a lot. It's like a designated driver. Friends don't let friends drive drunk. It's about making sure someone can get through an at-risk period safely. And so that's where a lot of my clinical work has come from. And I'll just say, I'm not a gun owner and I didn't come from a gun background. And so at the beginning, I was really nervous about how to do this. I didn't want to piss people off. I didn't want to sort of offend my patients. And part of my work with communities and also in the research space came from, I think, me as a clinician figuring out the words to use to do this in the right way. And I realized ultimately it was about me getting over my own nervousness and just starting to have conversations with people that were respectful, that acknowledge what I know and what I don't know, that acknowledge that I want to support them in making decisions. And then that's led to a lot of fun work that we can talk about. But I think, again, we as clinicians are in this really key place, I think, where we can have a huge impact on people. And a lot of it is about just starting to have those conversations.
Wonderful, wonderful. Thank you, Emmy. Dan, how did you tell us about a little bit about you and how you got into this work, this line of work, this field of work?
Most definitely. Thank you for having me as well. This is an awesome place to be able to discuss these issues and just kind of have a great conversation around firearm safety and storage, I think is the key. And like everyone else probably that has this passion behind, there's something that set that off. And for me in 2017, it was seeing a 4-year-old that was shot by his 6-year-old brother. And I'm a pediatric ER medicine doctor here at Cook Children's, and we see about 130,000 kids a year. So we're fairly busy emergency department. And so up to that point, nothing had clicked with me until I started having kids. And then I started to kind of see what was happening with my own kids and the risk that they were at, and the things that could happen to them. And kind of translating that to what I was doing in the ER. And so when that 4-year-old came in, I had my oldest was 4 years old at the time as well, and that just struck a chord in me. It was just something that was that made me want to make a difference and do something about it. It was more about, at this point, gun injuries, we would see them, here and there, but from 2017 and on, it seemed like we were seeing more of them. And so I decided to start Aim for Safety, which is a firearm injury prevention and awareness program for both children and adults. But I realized quickly that you can teach children all about gun safety, but to actually in practice get them to do the right thing every single time can be tough, right? They're developmentally, cognitively, where they're at. It's just hard for them to make the correct decision all the time. And so you don't want to make that tragic mistake, and so realize that parents are the key, right? Gun owners and firearm owners who storing their guns properly was the key to reducing unintentional firearm injury. And that I focused on that a lot because in our city, in our county, all the trauma that's 15 and above goes to the adult hospital. So everything I was seeing was 14 and under. So that's what I saw more. Unlike Emmy, who was seeing kind of the gang violence in those individuals, that 15, 16, and 17-year-olds and up into 24, we don't get to see that. Now, unfortunately, over the last 2 or 3 years, we're seeing more and more of that, and it's becoming more common even in our own institution to see a 14-year-old, 13-year-old involved in a gang shooting. So that's definitely disconcerting. But in addition to, we are seeing, at that age as well, kids with attempting suicide, and we still will see 1 or 2. They don't survive, but they're able to make it to us. But like Emmy said, the vast majority don't make it to the ER, don't make it to the hospital for any intervention. And so I think realize quickly that it's important for all of us to be a part of the change. If we want to see the change, we got to be a part of it. We got to get in there and talk to people. And as clinicians, we have a powerful role in that. We are strategically placed in a place where we are the common ground between one side and the other, because what we're trying to do is, help people reduce their risk, no matter across the board, whatever it is in my world, injury prevention wise, whether it's a pool, whether it's a car seat, whether it's safe sleep and firearm injury. So I think the conversation is not any different for me when I talk about firearm injury and prevention as it is any other injury prevention discussion point that we talk about. So that's what's been driving me, and I think what has been wonderful about Cook Children's is the resources that we have been able to put behind this, and it's I hear a lot of institutions talking about, gosh, it's so hard to get this going and moving, but Cook Children's has taken the lead and being able to say, hey, this is an important topic. We should be a part of the conversation. We should be in there doing something to reduce the risk and help our community. And I love that. And so I'm extremely excited about that opportunity and being able to move forward and then obviously provide the information to as many folks as we can.
Wonderful. Thank you, Dan. So, we know from the literature that even when gun owners are asked if it would at least be sometimes okay for a healthcare professional to talk to them or to ask them about guns, only less than 10% of that same sample say that any healthcare professional has ever asked them about guns. So these are adults. But again, these are firearm owners. And so talk a little bit about the barriers to that. What are the barriers and how can you overcome? You've written a lot about talking, as you just mentioned, talking to patients, and words matter. And so tell us about that gap and how we can sort of close that gap.
Yeah, thank you. So so I'm a clinician researcher, so I spend a lot of my time doing research and have done some work in this messaging space and sort of trying to understand patterns of practice. And then more recently, last year, with school medicine support, launched the Firearm Injury Prevention Initiative to try to grow capacity on this. So I'm going to answer from my own experiences as a clinician, but also what we know from research. So I think the first thing you have to pause and say, well, what is the context we're talking about? And I want to be clear here that, for example, in the emergency department, I don't think we should be talking to every single patient. I think it'd be fine to have like broad sort of posters messaging around secure storage is always a good thing, that kind of thing. Do I think that we should be screening every single person for whether they own a firearm? No, because I don't think that there's an evidence base for that in terms of what it would mean. Should I be talking to every suicidal patient about if they have access to guns? Absolutely, because we know that's an additional risk factor and that there's something I should then sort of do with it. So I think when we think about the clinician role, I, I want the folks listening today to know, at least for me, I'm not suggesting that this come up in every single visit you have with patients. You know, the sort of anticipatory guidance or general counseling, leaving brochures out, access to locks, like that can all be great. But I think we know some patients get very concerned about the direct asking and putting something in the medical record. So I think we need to be thoughtful about not doing that, honestly, if it's not indicated to be like specifically asking someone, do you own guns, and then put in the medical record. When we should be doing it though, so when should we be doing it? I think there are a couple specific situations. So I've already mentioned suicide, absolutely. Someone who's involved in a domestic violence relationship, absolutely, because the presence of a firearm significantly increases the risk of death for the victim. I think, as Dan mentioned, absolutely when there are kids in the house, that's where we should really be talking with all parents, anyone who interacts with kids, has kids at their house, like the guns should really be, locked up. We also should be thinking about this in the context of dementia. So if you care for patients with cognitive impairment from TBI or from dementia, that's also a place where it's important to talk about access sort of proactively. And then we think about community violence. It's a kind of a different model in terms of breaking the cycle for youth involved in gangs and so forth. And then the last one is individuals with substance use disorders. That's another sort of high risk period. And so the reasons why people may or may not bring it up on each of these might vary a little bit. I think at the end of the day, honestly, it comes down to two factors. So one is time. I don't know about you all in Texas, but we're really busy, and we've got to make it easy for clinicians to do this. So some of the things we've been doing, we built a tool, for example, called Lock to Live. That's a website that's something a suicidal patient can work through on their own, and then clinicians can kind of complement it. But how can we be smart about resources and tools and electronic medical record prompts, that kind of thing, because we're just busy. And does it have to be the doctor doing it, or can someone else on the care team be doing it? And then I think the second factor is comfort. And that gets to not wanting to make people angry, not wanting to say the wrong things, not knowing what to do if someone says yes. So what's the answer? Do you offer them a lock? You know, I had someone once say to me, if someone's suicidal and they have a gun, do I have to admit them to a psychiatric facility? Totally fair, honest question, because they just didn't know. Of course, the answer is no. Like there's a process you work through. But I think, the more I think we can educate clinicians and give them tools to make it easy to do this in the right context, I think that's how we get to a place where patients feel supported, patients don't feel offended, and we can really be making a difference.
Wonderful. Thank you, Emmy. Great advice. Dan, what about you? How do you approach, as a Texan, I'm leading in here because how do you approach patients? And do you agree with Emmy that it's not everybody, or do you have a different point of view about talking to folks?
Obviously, I mean, I live in two different worlds. I live in the pediatric world where, I think, and the risk of, let's say, a pool, we talk about that all the time. And it's something that, we don't talk about people shouldn't have pools. We talk about how to be safer with a pool. And I think that conversation should be had. And so I have a different opinion. I'm a firearm owner as well. So I freely admit that. And I think that helps for me to understand at least where people are coming from. But I think when you look at, should we be asking families? I think there's not enough time in the day. I agree with you. I mean, there's not enough time in a day or in a visit, right? So when you look at our pediatricians and the number of kids they see per day and trying to fit all of that injury prevention discussions in a 20-30 minute window is really hard, right? When you're trying to focus on certain things. But I think there are age appropriate discussions that we can have, when kids start to walk and are crawling and climbing, that we start to address those on a more regular basis. And then as kids get older and the transitions occur, and now you're adolescents and teens, then suicide risk, and still asking the same questions about firearm access. I think that's still really important. I'll take a step back. When I started doing this, I was like, okay, I feel comfortable with this conversation, but not everybody in our healthcare system does, right? So there's a lot of education. If we want to be able to at least provide some insight from a clinician standpoint, we have to be kind of aware of what those issues are and the problems and the solutions around those. So you have to take some initiative to go out and do that, or there's somebody like me who's helping the system learn that, understand that, and then providing the resource Aim for Safety if they need any educational materials for the office, or gun locks, or even gun safes, right? I think that's the next level that I think is really important for families and for our clinicians to be able to know, where can I go? If I get a question that I'm not comfortable with, who can I send them to, or where can I direct them to have that conversation? But if they're not comfortable with that, like you said earlier, only 8% of families feel, are getting those questions asked. And I think a lot of it may be that comfort level with our clinicians and our healthcare providers that, gosh, I don't know, I don't want to tackle this, politically divisive, conversation, but I think it's really important that we do, because it's of what we see, what I see in our ERs. And so I think a little bit different take than Emmy. I think we should be asking more, but our population is different, right? And I think there's an appropriate time and when you ask those questions to our families. And I think if we normalize these conversations, then no one gets offended. And I challenge all of those who own firearms like myself that to be the change and be willing to talk about it more openly, and also be willing to talk to other families about, if they're kids are coming over, or whatever it is, that they offer that information without that uncomfortableness, if you will, of being asked, because then that kind of puts parents at odds. And I think that's really a good way to kind of help all of us be able to have this conversation, normalize what's happening in our communities, so that we get to a common ground where we can discuss this, and there's not a political agenda behind it. And again, I have no political agenda. Emmy doesn't. I mean, the Texas Primary Care Consortium doesn't as well. All we're doing is trying to save lives, and that's the focus of all of this, is risk reduction, safety at the core.
Beautifully said. Now, so you both have used the term secure storage or safe storage. I think secure is now the preferred, because safe, I guess, has a lot of different connotations, right? And we can talk about that, or we don't need to, but I want to come back to something you said, Emmy, which was that I think you said that you didn't exactly know what to do. So let's say you screen somebody, you ask them, do you have, and then it's like, oh, what do I do? What do I do? And so I kind of use the analogy. It's like, well, if I measure someone's blood pressure and they have hypertension, I know what to do, right? I know what I can do. I can do a lot of things in my armamentarium. This is different, right? And so we do not in Texas have a ERPO or red flag law. We do not have that. Now, I think how many states, I forget now how many states do have so-called red flag laws. But I've been intrigued, Emmy, with the work that you've done, which I would call kind of a step down, right, to that, which is working with firearm stores and sporting goods stores and things like that. Would you share some information about that?
Yeah, I would love to. And this, I think, is an example of how, when you kind of get passionate about something and lean into it, sometimes you don't know where it's going to go. And it's inspiring to me to listen to Dan speak about kind of how he's just decided to jump into the space as well. So for me, some of this, and then I'm going to get to some resources for your listeners. So for me, I realized as a clinician, if somebody said, yes, I do have access to guns at home, I didn't have much to offer them in terms of where could they get discount locking devices, where could they store things. I realized I didn't even know what the laws in Colorado were in terms of what was legal for them to give it to someone else to hang on to or not. And every state's a little different in terms of what's required. So ER doctor wanting to fix it, we really leaned into trying to build up some resources for clinicians, but also then really for the general community, because I think we also need to recognize, particularly for suicide risk, many adults don't seek care. And so clinicians have an important role, but we also need to be thinking about how to get these messages out more broadly to the community. So the most recent iteration, which we're really excited about, and it's launching actually this month, we're working with the Department of Defense because they care deeply about service member suicide prevention. And we have funding from them to build up networks of firearm retailers surrounding military bases in the US to offer education, to offer free or discounted locking devices, and for shops that want to do it to offer on-site storage of firearms for service members and family members. And as part of that, I'm really excited. We actually now have a national map showing locations across the country of FFL, so federally licensed firearm dealers, who are willing to at least consider storing guns for people. And we'll put the link in the chat for folks. Please forgive if there are any typos on the website. It's like literally almost done. But I think it's an example of how we need, as clinicians, we want to be able to offer someone something. So if you're talking to someone tomorrow and they say, yeah, my husband who's going through a bad patch at work and I'm worried about and is suicidal, he does have access to guns at home. What do I do? You know, the basic message is you want to reduce access to that gun. So that can mean locking it up differently at home with a different kind of lockbox, or it can mean moving it out of the house, sometimes to a gun shop, sometimes to a friend or family member, depending on what's legal. Or a law enforcement, but most people don't really want to take their guns to the cops. And so you mentioned extreme risk protection orders. I do believe that those are an important part of the toolkit. I've cared for enough really concerning patients over the years to say there are times when there are people who pose a really serious danger to others or themselves, and we need to have that legal mechanism. But you know, earlier I was talking about, it's like friends don't let friends drive drunk, kind of designated driver model. You wouldn't call the cops on your friend the first time he's too drunk at a bar to drive home. At least I hope not. Like, that seems seems extreme, right? What do? As friends, you step in to make sure that he can get home safely. And I think we really need to be encouraging a model of that too, which is about the culture change, normalizing behaviors. Hey, buddy, I know you're going through a lot right now. I'd feel better if I could hold on to your guns for a bit. That sort of approach. Because I think that engagement and voluntary approach is really critically important. And then the last analogy I'll make to the traffic safety is I also fully agree with what Dan was saying around really promoting secure storage all the time, because it has many benefits in terms of preventing suicide and injury and so forth. And that to me is a little bit like putting your seatbelt on every time you get in a car. You don't know what day is going to be a bad day for your kid or not, right? Like, you don't know if somebody's going to come at you while you're driving down the road. And so you put your seatbelt on every day as a common safety measure. And then there's sort of additional steps you can take when someone's more at risk.
Wonderful. Dan, also about storage, and I know this is really part of your mission, right? Is literally taking storage out of the hospital into the community and teaching people, and not only teaching people, but providing. So tell us about your work with that, please.
Yeah. So I quickly realized, as a gun owner, I have some insight, right, of what my own storage practices were before I had kids, and understanding and growing up in Texas all my life, and kind of this generational effect of this is kind of how we did it. This is how I grew up. This is how I do it, and this is how we're going to continue to do it. And don't realize how that can really put you at risk. And so, as I looked within, I said, "Oh gosh, I need to change what I do at home." Early on as well, and started making those shifts. But also realizing, gosh, this is happening every single day. People, if it doesn't touch you, it doesn't. You don't feel like you need to respond to it. And so, but if you're touched by a firearm injury, then it obviously makes you want to make a change. And so, obviously, those are teaching moments that I don't want to be a part of, because that's hard. In many cases, for both Emmy and I, someone likely is not surviving on the other end. And so that's a lesson learned the hard way. And so as I started kind of getting out in the community, giving out gun locks, and that was kind of the standard, right? Giving out gun locks, talking to people, and realizing that I use gun locks, but I don't, if you have more than 2 or 3, you don't, you need that firearm. And I'll go back one step. Understanding why people have a firearm and why they have it unlocked and not stored, in a way that's safe, right? And everyone's different. And as you go out in the community, you talk to folks, you're like, oh gosh, you do it because of this reason, you're doing it because of this. And so you have to find a common ground with all of these folks and kind of meet them where they're at that makes sense, that works for everybody, but gives them the opportunity to immediately reduce the risk than just having a firearm in a nightstand or in a closet, and realize that gun locks, people take them, but are they actually using them? Because the vast majority of people who have a firearm that's close access is because they are worried about someone coming through the door and assaulting them or robbing them, something of that nature. So they don't feel like a gun lock is going to be the key in that case, right? To unlock that gun, put it together, all those kinds of things. So a gun safe became more practical to meet them where they were, to be able to say, all right, I know this is the gold standard. We're going to teach you what the gold standard is. This is to minimize your risk completely. Obviously, a firearm shouldn't be in the home with kids, but again, not practical in this day and age for a lot of people. So let's try this. Let's give you a gun storage unit, a gun lock, a gun box rather, that's a biometric safe or a key safe that you can still access it quickly if you need that firearm for whatever reason that you feel uncomfortable. And so it's been a lot of wheeling and dealing and talking to people and just understanding, why they do what they do and finding ways to meet that need. But we really all have to understand, and every family is going to be different. They're understanding why they need to do what they do as, I think, clinicians. And it's hard, the time we have with families for a primary care physician obviously is way more than I have. In an ER, I have 90 seconds to kind of strike up a conversation, 5 minutes total, probably, when you look at the amount of time I spend, talking to somebody, and trying to find where I can kind of discuss that. It's even harder when you're at a community event and people are just walking up to a table and you're trying to engage them. That there's an art to that I finally have learned, and I think I've gotten a little bit better at it, to be able to engage a lot of people with different tools that we use to open up the door to have a conversation. But I think storage boxes have become a real important part. We're going to start a study to see if there's a difference within, if we're giving out gun boxes, are people actually using them? And so hopefully, we'll have some more information off of that in the next year or two that shows that, yeah, this is effective, this is working. But I think anything better than what we are doing has to work, right? It has to be better than what we're doing now. And I think having those conversations is the key, and starting those conversations, being comfortable with those conversations is the key to normalizing all of these issues that we have.
So thank you. And so we've talked about the sort of individual level communicate, and I do want to just say a couple of things, and that is, there are some great tools out there, and you'll, for folks that look at our data brief, we talk about a couple of different resources. One is the Bullet Points Project, which is an interesting name, I think, but it's actually a great resource. It's from the University of California, Davis. And they have free CME where it's an hour. And so the healthcare professionals can really learn. If your knowledge base needs to be, strengthened, you can learn about, and again, to Emmy's point, that tends to make people more comfortable. If you know the words and you know what you're talking about, to be more comfortable. And there's good data. So Catherine Hoops out of Hopkins and others have demonstrated that medical students and residents who came into clinical care just not feeling comfortable talking about firearms or asking people if they're exposed to education about it, they can learn. So clinicians can learn. I think it takes some effort, right? But the point I want to make is that it is out there, and I think that clinicians can do this, and I think not only will you help your patients, but you'll feel more comfortable too, because as Emmy said, you both said, part of it is just feeling uncomfortable, and if you don't know the right words, or you don't actually know how to approach, then I think you can be more concerning. I know that both of you, so you both work in systems, healthcare systems. We've talked about individual and sort of individual and community, but so there's a whole other thing, and you mentioned this earlier, I mean, about community violence and things like that. And so that's another important aspect of this. And there are programs out there. The Hobby is one of them, which is the Hospital Alliance for Violence Intervention, I think. And it's a great organization. And so this is a situation where people come in to the emergency department, they've been injured, and there's a peer system. It varies in different places, but there's peer systems that pair them with someone who likely is, like them, looks like them, maybe probably has been the victim of violence, and really try to work through on the community level thing, which to me, that it's equally important. It is challenging, right? Because it requires mentoring, and it requires a lot of kind of intensive sort of therapy. Can you talk a little bit, Emmy, about community-based interventions like that? Not specifically Hobby, but just
Yeah. I think, thank you I think it's important that we, certainly that we talk about them. It is a very different approach than what we've been talking about so far. So it's not about, working with kids to say, hey, make sure you're locking your guns up at home, right? This is often a situation where kids, whether it's family, socioeconomic issues, struggles, insecure housing, right, problems at school, like it's a much bigger picture in terms of what's going on in that kid's life that is putting them in a situation where they are at risk of gun violence. And I do want to point out, actually, only it's a small fraction of community violence firearm injuries that are actually gang related. We have this perception that like any kid who's shot is somehow involved with a gang, and that really is not true. We do know that community violence clusters highly in certain geographic areas. So I think there's great models for how to set up these programs. So if you work at a larger hospital in particular, I think it's a wonderful thing to look into, depending on what's going on in your community and what the rates look like. Usually the programs, I think, are a partnership between the hospital and a community-based organization, again, bringing in trusted messengers and so forth. So it's really important. This goes back to sort of looking at that whole picture of violence and what's happening. And similarly, in domestic violence, it's going to be a slightly different counseling approach. You're going to have, where you're wanting to support a victim and making often her own choices, but also counseling on the if there's a gun present, it's going to change that sort of danger assessment. So for me, the take home is, as a clinician, you need to know the population you're working with. What are you seeing in your clinic? Where are the opportunities for you to have the biggest impact? And then there are resources for all of these issues, from pediatrics to geriatrics, that resources, then you can kind of lean into what makes the most sense for your own practice.
Thank you, Dan. Community.
We got to get out there and do it. It's as simple as, I think, I didn't realize here, at least in Fort Worth, the impact that a physician can make when they go out into the community and just talking to people. I think, and as I continue to do this, people will come back and say, "Gosh, it's amazing to be able to see you in the community talking to folks. They really appreciate that. They feel like somebody cares about them." And I think it's so right as far as when it comes to there's so many individual situations that are happening that we don't know, and trying to understand that and kind of finding ways to help improve that is important. But I think we all need to get out there and start just talking about it and discussing the concerns. We're actually part of something called the 1 Second Collaborative. We're, with hospital intervention, programs. What I've seen here and what we found in Fort Worth with the 1 Second Collaborative is that there's so many silos. Everyone's working together for a common goal, but we're not working together because we don't know we exist. And so I'm working with, the largest hospitals here, JPS and THR, as well downtown, to develop and start to put together these intervention programs so that we can kind of find these folks at at a point where it's a learning opportunity for them. It's a teaching moment that they're coming in, they're looking for help. We can kind of start to address those social determinants of health that may have put them there, that we can help them kind of get out of whatever situation they're in, whether it's related to, obviously, gosh, you just lost my train of thought. Whether it's related to domestic violence or perhaps the small percentage of gang violence, but there's a part for all of us to play. I'm working with one of our bishops who is a violence interrupter, providing them gun safes to provide to folks that he isn't, has in the community. So there's a way to kind of help everywhere. It's just a matter of getting out there and finding where you can have that reach. And that's important. If you don't, if you don't know and you're not trying, then obviously we're not moving the needle. But if you get out there and just talk to the people, even in your office, you can start to get a sense of what's happening around them that helps you to shape kind of those conversations and what you can offer them. But also knowing as a clinician, where do I send them for those resources? If we don't have that, you don't have that in your armamentarium, your tool belt, then we can't help them. So I think it's really important. We just need to be aware, get out there, start talking to folks, and having conversations to normalize the firearm kind of discussion, but also to know what people's needs are and what we can provide them. I hope that answered it.
Yeah, no, absolutely, absolutely. And, I think one of the real challenges in the world, the society that we live in here is becoming inured to this, right? Becoming inured to, oh, there's another, and I think that's sort of a protective mechanism to some extent. I'm not play amateur psychologist here, but I think that if we every day we internalize all that, it's just, we can't even really probably function. So that needs to be avoided if at all possible. And we don't need to become inured. We need to, every situation that we know about, take that into account. But how do you, I guess I would ask you, this is tough work for both of you. This is tough work. Your clinical work is tough. When you talk about kids drowning and, accidental shootings and, abuse, et cetera, very tough work. Same with you. With substance use and the things the depression and suicidality, things that you see more in adults. What gives you hope, and what keeps you coming, hopefully to work every day and continuing to do this work, which is tough work? Emmy, how do you keep?
Well, yeah, I try to have a whole list of self-care things that we won't talk about. That includes skiing, of course, because I live in Colorado. But I'm feeling really optimistic about what's been happening in the field. Even a few years ago, I don't think we would have been having this webinar. I think a lot of the work I do with firearm businesses and firearm organizations, education organizations, it's a totally different conversation now than just a few years ago, that people have really, I think, realized, yeah, we actually are just trying to talk about preventing injuries, that this is not about gun rights or gun control or political divisiveness. This is actually a space that people all agree. We all want our families to be safe. Nobody wants our kids dying. Nobody wants our family members dying. And there's a lot we can do. And so I feel very optimistic about that. I will say too, in a time that is particularly divisive when it comes to politics and sort of people becoming entrenched in their own bubbles, this work is endlessly fascinating because you get to work with people from all different backgrounds who probably disagree on a lot of things and yet work together in really beautiful partnerships, sort of across the whole spectrum. And I think that, to me, sort of restores my faith to some extent in our ability to do that kind of work. Whether we can fix politics, I don't know, but maybe we can save some lives at least.
I like it. Dan?
So an example was yesterday. I did a train the trainer. So we get 20 to 30 folks who are interested in being able to kind of provide the message that we deliver, and we give them a toolkit, and to walk into that and kind of talk to those folks who the vast majority of them are firearm owning participants, to see that they want to make a difference, they want to make a change, that those folks are coming to the table. And like Amy said, the political side, it's a whole other realm. But but to know that people are engaging and willing to have this conversation, are willing to come in and go out there and talk to folks and have, take on, not just a clinician, but just, there's a couple of folks, that was a lawyer in there, there was a CPA who's willing to come on and take this challenge on, and they own firearms as well, because they want to see a change in the community. And so that drives me. I mean, that's amazing to be able to see these folks with the passion that I have to do that, plus seeing the kids. The kids, they feel, I love being able to talk to kids, because they provide some insight as far as they feel like they're stuck in whatever life they are, and to be able to mentor them and help them and show them that, gosh, this is not your destiny. Your destiny is whatever you want it to be. You just have to think outside of what you think your bubble is to be able to achieve that. And to see them be able to do that, and kind of that light, that glimmer in their eye, kind of, you say, oh, yeah, maybe I can do this. And I think that's what drives me as well. I mean, just knowing that the kids are our future. Borrow that old cliche. Kids are our future, but it's so true. And so many of them need the opportunity, need to be able to see that there's more out there than what their little sphere, and what's happening that they can achieve. And that really kind of helps to drive and fire the fuel for me to keep on moving.
I love both those responses, and it reminds me of something I read this morning, that Kaiser Family Foundation, on their daily website, or their daily news, I don't know if you saw this, with their first article, was about how even public health researchers don't really understand that much about research. The reason, but to make a long story short, most people know that in 1996, the Dickey Amendment, so-called, essentially prohibited federal funding for research for firearms. And the person that was head of the CDC firearm injury, Dr. Rosenberg, I don't know if he quit or was fired at that time. But the story and then, what has happened 30 years later, but the story is, he and Representative Dickey became friends. Representative Dickey was like, you know what, I was wrong. And so, okay. So I guess, to me, that's a kind of an extreme example, but it's like, okay, people can change their minds, and they can look back and say, yeah, now, of course, 30 years almost have gone by. Now, the good news is we are starting to get some funding, right, for research, Emmy. And I think we're starting to see some high quality research. And that is foundational, because we really, we know a lot, but there's a lot we don't know, right? And so I think in any kind of healthcare endeavor, we need that high quality research and data. And so I think that is starting to happen. Would you agree with that, Emmy? Are you starting to see more?
Yes, absolutely. It's hard, because we are a couple decades behind in terms of where we should be at. So it's frustrating to not know what works and exactly what programs to put in place, but change is coming. And I think the federal funding has been huge, foundation funding, more and more junior researchers wanting to enter the field because they actually can build a career. I mean, I, like many people, was warned away from it and just didn't listen. So again, I feel optimistic about that as well. And I think particularly that I think there's really an awareness of the need to think about broad perspectives, a broad range of outcomes. Like Dan was talking about earlier, sort of, why do people own guns, store them the way they do, sort of really recognizing that these are complicated issues with cultural, historical, political, geographic nuance. And how do we then think about that for our interventions, and build that into the research that we're doing, so that we can build programs that actually will work for people where they live? So I feel very optimistic about kind of the state of the field. We certainly need ongoing and ideally more funding for research, but at least it's in a better direction than it was.
Yes, we'll take it. We'll take that progress. That's that optimism, right, that you have to come to work with. Dan, any additional thoughts on that?
Oh no, I agree. I mean, it's amazing to see, as I go to different conferences, that the amount of research that is being conducted, and people are excited about it. I have a group of 12 surgical residents at Texas Health that are excited about just what we're starting and what we're doing in the community work. And so I'm excited about them being excited. And so I think that, there's definitely a lot of work to be done. And I think there's no one size fits all model. I think that's really key. And that's why having the conversations is important, because there's not going to be one one program that's going to fit every situation. It's going to fit the vast majority, but there's still the nuances of each individual gun owner and what drives them and how we have to reach them. And that's why, for me, community efforts are so important. That one-on-one is really key. I relish that opportunity to be able to talk to people and discuss things with them, because it gives me insight, it helps me build a better program. It helps me speak to it better and provide better insight.
I do want to just point out that there is a national, and there are several, but there's a national initiative Emmy and I are involved with, and that really came from, and I have to give credit to our friends at the American College of Surgeons. They have done phenomenal work with this, as have other organizations. But to the American College of Physicians, American College of Surgeons, Emergency Medicine, American Academy of Pediatrics, and the Council for Medical Specialties have formed a kind of a coalition, and we have 3 work groups looking at medical education and looking at policy and looking at the third one I can't remember, but and so there is, as a national initiative, there are things that are ongoing. So good. Emmy answered about the question about comms. So I do have one question, and then we have a couple of minutes. So we here in Texas are always looking to our next legislative session. So our next legislative session will start essentially January 2025. And so we have been really working with our colleagues and our stakeholders and our folks to really see what we can do, what we can in this state, what we can propose that would be doable in terms of just knowing what the current political situation is. Again, we've all said this is nonpartisan. It is definitely nonpartisan. But what are some things that you all think are, I don't want to say low-hanging fruit, because that's not even a possibility, but what do you think are potentially mutually acceptable interventions that we might consider for our interim?
Yeah, well, I always come back to sort of, how do you make it easy for people to do the right thing? And by the right thing in this case, I mean always storing weapons securely so they're not accessible to unauthorized people. So I think that can mean, how do we get locking devices to people, not just cable locks, because a lot of people won't use a cable lock, but how do you get people the devices that they're willing to use? Is that through incentives? Is it through programs that give them out for free? The VA funded a pilot program where veterans could get free locking devices. So, how can we get smart about thinking about making it easier for people to get the things that they'll actually use at home? How do we continue to normalize that conversation as well? That's hard and that takes time, but I do think that the physical provision of devices can go a long way in terms of reminding people to do something, but also just, again, making it easier for them to do it. On the legislative front, I think I'm really interested in 2 states in Louisiana and Washington have passed laws providing some liability protection for firearm businesses that store weapons for people, because that's been one of the big barriers. And the Louisiana law was actually unanimous and bipartisan, which is insane to me. It's the last time that's happened. So, I look at this again, really from a space of what are collaborative, sort of positive actions we can take as opposed to punitive, I think is how we continue to really build momentum in this space personally. But that's also because our organization kind of intentionally doesn't do a lot of legislative advocacy work.
Sure. State institution. Dan, what about you? And then we're going to close up.
Always an interesting question, because I try to stay out of the political forum. But I think there are certain things, providing incentives like a tax holiday to buy safes, or even a certificate from the state that says 50% off to get a safe. There are things that, thinking outside the box, thinking outside that legislative the pro versus not, have a gun, not a gun, thinking of how do we get these, like Emmy said, get these devices in people's hands. I mean, that's the real key, I think. And that's where I think both sides can maybe come together to move that. I'm happy that, we're able to talk about it in schools, that schools are going to be required to provide that information. That's a huge step forward in my world, because there's always been that, oh, well, we can't let you in, we can't do this because of, and so that has been a great door opening to provide that education to the kids as well. So, yeah.
Fantastic. One last minute for if there's any question that hasn't come forward. We have like a minute. My team, I guess, I don't think so. I answered all the questions. Well, I want to thank everybody for participating. I want to thank our panelists. They were fantastic. I think this is really the beginning of a wonderful conversation, and we look forward to continuing to work with you all and to work with the stakeholders, people that joined the webinar today. Please let us know how you like the webinar. Please share any thoughts that you might have. And we really all want to move together to keep our patients, our fellow Texans, and their communities safe. So thank you very much for being with us today. Thank you.